Is the mute? Okay, so my dear friends, so this program will be a very interesting one because I'm planning to make it as interesting and as palatable as possible, involving all of you. So it will be definitely a very well, sought after program. I'm sure about it. So we're going to deal with basics as well as advanced techniques. So I'm going to share my screen and start, talking about what I have in my mind, that is from my heart. And this is the you are. Okay, so the agenda which we have planned. Okay, so the agenda which we have planned is this. So this is the plan for 2026. So we'll have regular Zoom meetings as often as possible, maybe not daily, but maybe at least 3 or 4 times a week, which will be given as a timetable. And this will not only involve rhinology or otology, but involve all the spectrum of ENT. So we are increasing our Zoom capacity to 300 or 500 people because 100 is almost full every time. So the live surgeries which are done in the morning, which are always live. Tomorrow we have, I think, maxillectomy and skull-base osteomyelitis and things like that, which will be live. But what will happen is, since you are not able to ask questions, the same thing will be also available on YouTube, and we'll also post it as a topic. So we can dissect that surgery and discuss that. So that will be our agenda. Then I will try to invite speakers for all topics. I already talked with a few people abroad as well as in India, the top doins or in that particular field. So it should be very interesting. And common ENT problems for PGs will be discussed. Main problem I am seeing with the many young residents who come here is actually the OPD diagnosis. So people, for example, I'll just tell a simple case of ear discharge. And if the discharge is just in the deep canal, they are not able to make the diagnosis as deep or it is external. So deep or they make it as automycosis, and that is exactly opposite. You have to give a different drug for this, different drug for that. So what I'm planning to do is to every day we'll put 5 scenarios and we'll discuss about the OPD diagnosis, how to see the OPD. So I want to talk to all the medical colleges and catch hold of all the HODs and also assistant professors. And we will try to make a sort of PG teaching program. I'm sure that it'll be very useful for presentation. We've already done that, but then we will do it on a regular basis, not only during the exam period of time. Okay. Okay, so now another important thing which we want to do is I want to increase the unedited videos in the YouTube channel. And you're going to see a lot more videos in ENT University channel. So please subscribe and you will find a lot of videos, all unedited videos. And what we are planning to do is to open this hospital and Chennai center is going to start from February. So Trichy and Chennai centers, and there'll be a free observership. It'll be totally free of cost. And if they are very poor, I'm prepared to pay for the to and fro also. So we will also talk with some foreign universities. I know very a lot of universities like Italian universities and some of the Taiwan and all. I'll talk with them and I'll try to fix some exchange programs where their postgraduates or maybe senior residents can come here and our senior residents can go there. Okay, so this is the one which I wanted to talk from my heart. And I think today's capacity is 100. Please don't mistake me. From tomorrow, because it's a Sunday, I couldn't increase the capacity. Now, let us now go on to what we're going to talk today. And the topic of today is a very basic topic, namely surgical techniques in endoscopic sinus surgery. And everybody does Fess, right? Everybody does endoscopic sinus surgery, but post-operative care is something which many people are a little confused about. How do we take care of this cavity? Why does it fail? All this is what we're going to discuss. So how to improve the results after an endoscopic sinus surgery. So this is the topic of today. My cursor already. Why is the cursor not coming? Okay, fine. I am not able to. Okay, tomorrow get it done. So I have been visiting professor of Department of Neurosurgery in Vietnam. I have been conferred neurosurgeon from these two universities, and it's a big honor for an Indian to have such a prestigious post. Okay, I hail from my college. I'm so proud to say that I'm from Madras Medical College. And that's where I learned everything. I dedicate this lecture to all the teachers, especially Professor Gananathan sir, also Professor Sethi. He was the one who really instilled knowledge about endoscopic sinus surgery to me. Now, we are not going to discuss about all the other aspects, straight away going on to surgery. So we have a patient who presents to you with clear, that is the Lund-Mackay criteria satisfying surgery. So you're planning for surgery. What do you do? This is what we are going to discuss. This is a basic topic for postgraduates, but even some consultants have some problem in, tackling this. Okay, let us see this. So I'm not going to post this because I'll do that last. Surgical management, the commonest way Fess is done. So basically,
The house is full, sir.
Hello?
The house is full. No more
Ah,
space is there.
no. Today only it's 100. From tomorrow we'll increase it, boss.
Sir.
Because I just paid it and they said tomorrow you can increase the capacity. So from
Sir.
tomorrow we'll have more capacity, and it'll be from 8 the morning and evening. Both times we'll be having lectures, both live surgery and lectures. Okay. So, right. Thank you. Now, surgical management, how is Fess done? Let us see one common Fess being done. So this is how the surgeon goes with the endoscope. And what happens is that he tries to, bite, pull, pluck. And basically what happens is they cut the inferior turbinate, they cut the middle turbinate, and they do everything possible to try to, enhance the results. But actually, how is success determined in endoscopic sinus surgery? The problem is we select the case badly. So the first is the case selection. Second is the surgical technique. Third is a post-operative follow-up. Of course, good training is very important. Okay, now let us see this particular case. So please understand that in pediatric individuals, when we take a scan during an attack of cold, it will always show sinusitis. It will involve sinus, maxillary sinus, sphenoid sinus. I have till date generally avoided surgery in pediatric sinus disease. I want to make it clear. So pediatric sinusitis is generally a medical disease. So it can be secondary to adenoid, or it can be secondary to an upper respiratory tract infection. So try to treat pediatric sinusitis by medicines. So what is the medicine you will use? I generally use mometasone spray, as well as some nasal douching, and preferably an antibiotic of choice, which is generally amoxicillin. So this is what I generally use. But for adults, you're seeing a patient with attack of cold and you want to operate, it is wrong. You can't operate. You have to give what is called maximal medical therapy. So what is maximal medical therapy? Maximal medical therapy, as defined by Professor David Kennedy. You know who is David Kennedy, right? David Kennedy was the one who named Fess as Fess, functional endoscopic sinus surgery. The name was given by Professor David Kennedy, University of Pennsylvania. Now, he has described that you have to give culture-directed antibiotics for a period of 3 months, at least 8 weeks, minimum. So that means you have to give culture directed antibiotics for 8 weeks to 3 months. Then second is you should give intranasal corticosteroids with nasal douching. And generally we avoid antihistamine. But if you have allergy super added, then you can add it along with lower airway. If it is involved, then you can add Montelukast. So, but pre-operatively, you will always look at the turbinate. You look at the inferior turbinate. This is very important, my dear friends. Whenever you see the pale mulberry appearance of the inferior turbinate, send the patient for a total eosinophil count and an IgE count. And if the IgE count is high, and if you are given maximal medical therapy and the patient still has sinusitis, chronic rhinosinusitis with allergy, please understand you are not going to get a very optimal result unless you combine your surgery along with allergy directed medicines, like for example, immunotherapy. So basically in our center, we follow that routinely. We not only operate, but we also give immunotherapy. Okay, so now that is about maximal medical therapy. Let us go to the next. What is the surgical technique involved in increasing your results? Many people nowadays have started talking about rebooting surgery or rebootal. If you have seen the papers, many papers now, research papers, they talk about rebootal. That is, what is rebootal? Rebootal is nasalization of the sinuses. So that is called nasalization of the sinuses. What did they do in that? They strip the mucosa. And that is done. If you do that, what happens is the mucosa contains goblet cells. It contains a lot of, mast cells, and they are very protective to the environment. And if you remove that, you expose raw bone, and raw bone will lead to osteitis. So that is the reason why we don't advise stripping of mucosa in chronic rhinosinusitis, because you need anti-inflammatory effect from the mucosa as such. That's why. So what is the best instrument used when you're doing chronic rhinosinusitis? Never use a Blackesley forceps. So you can use a through biting forceps or a debrider. Debrider is the best way to save mucosa. And basically, it's not advisable to do drill outs unless it is really essential, because drill outs can again cause osteitis. And osteitis is a dangerous thing, and it can produce recurrent biofilms and sinusitis. Now, let us go to the next slide and see what is the key to objective success. So how do you standardize your technique? So basically, when you're operating, you should have some kind of standardization, right? So that is why they brought this called MIST, minimally invasive sinus technique. So do minimal, do as less as possible. Don't do too much. So what I follow is what is called the one cell up concept. What is the one cell up concept? That's again given by Professor Stamberger. Suppose you have antirhythmoids involved. We just open one of the cells of the posterior rhythmoid. Suppose the maxilla is involved, I open the antirhythmoid. So this is how basically, in case of chronic rhinosinusitis. So basically the frontal is avoided. Frontal don't touch unless it's involved. Apart from that, he says you do a one cell up technique. Now let us go to the concept. Of course, this is one thing which has changed in the due course is infiltration. We never infiltrate. Do not infiltrate. Do not infiltrate. Again and again, I say, do not infiltrate. If you infiltrate, then you are back by 2 decades in endoscopic sinus surgery. Now, nobody infiltrates. If you see all the top guns in endoscopic sinus surgery, nobody infiltrates. So now again, medialization of the middle turbinate. If you have no space for you to enter, then I have a specified technique to medialize the middle turbinate, which I'll be telling you. Okay, uncinectomy and 3 layers to be removed, all that. Then you go for either a bulla up or a bulla down technique. It depends upon what sinuses are involved. Now, of course, we will now go and see what is the kind of surgery which we will plan for a concha bullosa. See, concha bullosa surgery is generally not required in many cases. Many people talk about Schluter's neuralgia. They talk about anterhythmoidal nerve syndrome. And there is a big query whether it exists or not. But yes, we find it in some patients. And this can cause an anatomical problem by actually compressing the uncinate process, and that can cause sinusitis. So it's an absolute indication for surgery. So if this is causing sinusitis, it's going and you see with an endoscope, it's touching, then it is an absolute indication. But sometimes what happens is it can even push the septum. I've seen this huge, and it pushes the septum, and that middle turbinate becomes paradoxical there. So these are all because of the pneumatization of the middle turbinate. So whenever you do concha bullosa surgery, this is all my previous videos, you have to always start your incision from below upwards. Never start from above downwards. Why? Because this middle turbinate has got a medial lamella and a lateral lamella. And when you pull it from above downwards, you can fracture it. I saw one patient where the concha bullosa was excised and the patient presented with the CSF leak, cribriform leak. So never do that. Do from below upwards. There are various kinds of concha bullosa. All that will be discussed later. And so what will happen is you just slowly get that mucosa out, and then you can take this and always try to look for the ostium of the concha bullosa. Generally, the ostium of the concha bullosa drains into the posterior points. And if it drains into the posterior point, it's called, can anybody answer this question? It's called the cell of Grunwald. It's called the cell of Grunwald. Okay, so then you see here, this all uncinate and all I'm going to teach you as a practical class. This will all become instructional course. So I'm just telling you how to do it. So basically, we do what is called the uncinate flap. We'll do a practical session of instructional course on Zoom itself. You'll see that. So always try to open the natural ostium. This is very important. And see here, this nowadays we do what is called the hanging technique. I think you have seen me doing it a lot of times. But this was one time when I used to do a lot of uncinate flaps. So what is the advantage of an uncinate flap? You remove the bone and the inner mucosa is laid over the outer mucosa. See that? It's like this. What is the advantage? David Kennedy did a study which said that if you raw the surface of the mucosa all around, the incidence of stenosis in a maxillary sinus can be as high as 10%. So that is complete stenosis is 10%. In my own cases, I've seen my residents operate and I will not even see the maxilla. It will be completely closed. Why? Because they have screwed all wrong and they have not done any flaps. So you should be careful that at least 270 degrees of the circumference is not damaged. Unless you see that you are going to have a stenosis. Please understand that. So, and then what you do is, of course, this is the uncinate. And then basically, when you're doing a bulla up technique, which is described by my teacher, Professor Sethi, you just see that you watch upwards, you see the half egg, and then you do what is called the Stamberger. You know what he says, you just have to uncap the egg. So this is how I do it. I mean, take the bone and then the mucosa, and then gently reposition the mucosa. You will see that frontal sinus. Of course, this patient didn't have much disease. I just wanted to show it because of the anatomy. Okay, we always face this problem, antroconal polyp. Many people think antroconal polyp is easy. Believe me, I have seen a lot of recurrence in antroconal polyp. Late Professor Stamberger used to say there are two conditions in endoscopic sinus surgery where you can give 100% results. Number one is antroconal polyp. Number two is fungal ball. So these two are the best. But I see a lot of recurrence in antroconal polyp. Why? Because you have not done it scientifically. So there are various techniques to do an antroconal polyp. This is an AC polyp. You see here. The first step in antroconal polyp surgery, when you see that, is you keep adrenaline pack and then you just have to. So step one is press and decompress this polyp. So you have to chemically and mechanically press it, mechanical pressure and chemical pressure. So you have to do this. Once you do it, it'll get shriveled. See, it's got shriveled. Then what? Wait, who is that man?
Shakti Singh, please mute yourself. Shakti Singh.
Participant.
Dr. Shakti Singh, please mute yourself. Don't disturb, please.
Engama, where is he?
Shakti Singh from. Okay, carry on, sir. No problem.
Where is it? Mute. Where is this mute? Huh?
Mute all, mute all.
Where is mute all?
Chat across chat across.
So nobody can talk now. I'm muting
Yeah.
everybody
Okay.
because I don't want to get disturbed. Huh? Okay, share. Because this topic might sound very simple, but many people are making mistakes in this itself. Hey, what is this, man? Okay, now you see here, the first step in antroconal polyp surgery is you try to keep adrenaline. This is 1 in 1,000 adrenaline. Many people ask, what is the dose of adrenaline? It is unquantified, undiluted adrenaline. Please understand. Many people ask, sorry, I'm having a lot of cold. Can you use 5 ampules? Can you use 10 ampules? Can you use 20 ampules? It is immaterial. Whether you use 1 ampule or 10 ampules or 100 ampules, it's immaterial because it is unquantified, undiluted. Please go through the paper of Professor Stamberger. Okay. So, if you add 100 ampules, 100 ampules, because adrenaline prevents adrenaline absorption. It produces intense vasoconstriction. So, even if you put one, you should not infiltrate. You have to pack. It's just pack. Please understand that. So, I am packing now and see what happens. Once I pack, it gets shriveled. So what is the advantage of this? You have a nasal part, you have a choanal part, you have a antral part, right? So the pedicle will be seen. You cut off the pedicle. So once you cut off the pedicle, what happens? The choanal banking effect goes off. Once the choanal banking effect goes off, then you can see that. See how nicely you can cut off. You can chop it off. Usually this polyp arises from the axillary ostium only. So you have to find out the natural ostium. So I have removed this part of the polyp. Once you remove that, you have to go ahead with an uncinotomy. So very important. Don't just start debriding. You have to identify the natural ostium because an antroconal polyp arises from the axillary ostium. You please understand this. Now we do the same technique, that is the uncinate flap technique, or you have to widen it. And once you widen it, you have to put in a 70-degree telescope and then see the attachment. So you have to remove that's a Hugh-Weiser forceps being used, and you have to remove the attachment along with a normal surrounding mucosa. Very, very, very important. Of course, this antroconal polyp is simple, right? But there are many cases where there will not be a single attachment. You will have multiple attachments. What do you do if you have multiple attachments? Then you have to remove each and every attachment. How do you do that? You can do a prelacrimal approach. So this is where you have to get trained in a prelacrimal approach. Of course, all this will be dealt with in detail. I'm just starting the first lecture so that you will. So let us go to ethmoidal polyp. So you can see here, ethmoidal polyp, first of all, how do you prepare this case? You should understand this. Many of my own residents don't know how to prepare an ethmoidal polyp. Number one, you should start the patient on antibiotics. Okay, so preoperative antibiotics for a week. And then you should start the patient on a preoperative dose of corticosteroid. Prednisolone 30 milligram OD or 10 milligram TDS, 30 milligram totally per day for a period of 7 days. Non-tapered dose. Non-tapered dose. You should not taper the dose for a week. What it does? It doesn't shrink the polyp. It makes the field better. Please understand, you are not trying to shrink that polyp, but it makes the field better. So that preoperative steroid with nasal douching, corticosteroid spray, and antibiotic. Antibiotic, why you are giving? Because sinusitis secondary to polyposis will go off, so bleeding will be lesser. So this is why you are giving antibiotics. Now, you can ask me, sir, we are giving steroid. Okay, let us give steroid for a long time. Polyps will go off. why you have to operate? This is a very common question asked to me. So there is a beautiful study by Fulda group is Professor Curl, that is draft group, which has a time-lapse video. I have that video with me. So what happens is that if you give the steroids for more than 2 to 3 weeks, slowly, initially it will start shrinking. The polyp will start shrinking. And then what happens is that after 4 weeks to 6 weeks, there is a rebound phenomena. So what happens is there is sorry, the polyp starts regrowing, but more importantly, what they studied was there is deposition of fungus. So you're converting a normal polyp into a fungal polyposis. So this is why we don't give long-term corticosteroids orally for a case of polyposis. So it is definitely a surgical disease. So what do we do in such cases? So we give preoperative drugs, and second is we give them. We always try to do an eosinophil count, and second is we do a IgE estimation. So preoperatively we can prognosticate this disease. Very important. So any polyp you have to do an IgE estimation and an eosinophil count. And if you find that the Ig is very high, then we have to follow it up with some medical treatment, because you are just treating only the local manifestation of a systemic disease. You understand that very clearly. So if you have read the latest EPOS, you will understand. So you have to read the EPOS. Okay, now let us see how. So the technicalities of this surgery, of course, we'll be showing it in a big way. Same way, see the concha bullosa. This is causing polyposis. You have to operate, my dear friend. You cannot leave that concha bullosa. Now, again, I'm using a through biting forceps. And then what happens in case of polyposis, many people, what they do is, if the polyp is coming anterior to the middle turbinate, see, it's completely blocking, they just start debriding, including the turbinate, they will debride. Please understand, in a case of extensive polyp coming to the vestibule, the most important step of that polyp surgery is to identify that middle turbinate. If it can be leaf-like, it can be just like a leaf, or it can be totally polypoidal, it will be buried inside the polyp. But if you have identified the middle turbinate, you are a super Fess surgeon, which I've seen in many surgeons. They don't do it. So the first step is to identify that middle turbinate, and then you get beautiful landmarks. And a person who does a backbiting uncinate, uncinatomy with a backbiting in a case of polyp, is a super Fess surgeon, believe me, because many people don't identify the uncinate process and they just debride, but they don't do a proper job. So if it is extensive, you should be able to delineate the uncinate process. You see what I'm doing? So this is the uncinate process, and see, you have to. So this is the uncinate process, clearly seen, and you have to do a backbiting. See, this is done with a sickle knife as well as a backbiter, and then we identify the. So now I can tell you, suppose you have a revision, you don't have any landmarks. Which is the best landmark? I'll tell you this very important point. Many people make a mistake here because sometimes the middle turbinate is cut. Middle turbinate, if you cut, you are a barbaric surgeon. Please understand, you should not cut the middle turbinate at any cost. You can trim it, but you cannot cut it completely, because you are not the last surgeon in polyp. So the best landmark is the inferior turbinate. So this is 9 millimeters behind the anterior end of the inferior turbinate is the nasolacrimal duct. Please understand. That is roughly 1 centimeter. 1 centimeter is the opening of the Blekesli. So you keep that and then go behind. You will definitely find that is the natural ostium. Very simple method to identify. So the next, once you've got the maxillary sinus ostium, you widen it. The maxilla is a road map to all the sinuses. All the sinuses. Why? The anterior part of the maxilla, you draw a line upwards, it corresponds to the anterior wall of the frontal sinus. So the maxilla, if you draw a line from the anterior wall of the maxilla, you draw it upwards, it's the anterior wall of the frontal sinus. The superior wall of the maxilla, and if you draw a line, that's the ethmomaxillary crest. And the posterior wall of the maxilla, you draw a line along the coronal plane, corresponds to the anterior wall of the sphenoid sinus. See how you can get all the sinuses with the maxillary sinus. So that is why I again and again say, if you get the maxilla, then you can get all the sinuses. So the first step in a revision case, imagine it's a revision case. I will go 1 centimeter behind the inferior turbinate, and then I'll open the maxillary sinus. I will widen the maxillary sinus, get the maxillary crest. Once I do it, I can either go bulla up or bulla down. But what I do now is I will go and identify the ethmomaxillary crest, and then I will open up the bulla. I will delineate the lamina papyracea. See that? That's the lamina papyracea. You have to delineate the. This is very commonly done mistake, my dear friends. They don't delineate the lamina. So much of cells are there in the lamina papyracea, and that is not the right way to do it, because lamina papyracea will give you a clear-cut way to the posterior points. And then you just do a gauze piece technique. This has been published, I think, by Professor Sinia of Russia, and she's my student again. So I will share with you the article. Then, of course, the Jula technique, which I have been teaching, identify the superior turbinate. So to open the sphenoid, there are 3 routes. Please understand, there are 3 routes. Many people still are struggling to open the sphenoid sinus. My own residents, right from big colleges, they are struggling. It's very simple, my dear friends. There are 3 techniques to open the sphenoid sinus. See here, this is the maxilla, this is the ethmomaxillary crest. You go back, it's the posterior ethmoid. From the posterior ethmoid, you should see that you cannot see the base of the sphenoid sinus. If you see the base of a cell, it's not the sphenoid sinus. You should understand that. So this is the posterior ethmoid. You can just dip your suction tip infero-medially and you will enter into the sphenoid sinus. This is point number 1. But it's not a good technique. Even though Professor Stamberger told this technique, it's not a good technique. The best technique would be you just go behind the bulla. This is the bulla. This is the bullar lamella. Just draw a line here, and then you go straight near the septum. You will find the superior turbinate. So this is what is called the Jula technique. I'll be demonstrating it to you this year, 2026, and you will see a lot more teaching programs from me. And you can see that this is the superior turbinate, and if you go between the superior turbinate and the septum, and you just look at the ethmomaxillary crest, that's our noddy cell. You get the minute you see the base. It's a pyramidal shaped cell. It pneumatizes around the optic canal, and that's you see that this is typical of a noddy cell. So don't mistake it to be the sphenoid. Again, you're not seeing the base. You see, if you see the floor, it's not the sphenoid. Again and again, I tell you. Again and again, I tell you. See, now this is the noddy. This is the sphenoid sinus, and the ridge which separates it is called the Parsons ridge. Always, my dear friends, whenever you find a noddy and a sphenoid sinus, you have to connect both. If you don't connect both, that means you will land up in stenosis. So stenosis of the sphenoid sinus again, or ostium will be there. See that? This is the Parsons ridge, very clearly seen. So that's a Parsons ridge, and you can connect both. That's the optic nerve. Don't be afraid to connect both. You can easily connect both. And once you connect it, you see that? That's the sphenoid sinus, that's the sella, and you can see pus there. And you have to connect it. How do you connect it? You can use a through biting. You can use a punch forceps, and you can connect it. Always, always, always get the plenum. So that's the plenum here. So once you get the plenum, come backwards, come backwards. If you come backwards, you will clearly get the roof, ethmoidal roof. See that? That's the best way to get the ethmoidal roof. Use a 70-degree telescope, and you can beautifully do what is called the gauze piece technique for the frontal sinus. And once you do that, take a rad 60 debrider blade, and you see how beautifully the frontal sinus has been opened. Remember one thing, my dear friends. Many people open only this part of the frontal sinus. Wrong. The frontal recess consists of the opening of the frontal sinus along with the anterior fovea. So that means the boundaries of the frontal recess are, you see, this is the boundary of the frontal recess, anteriorly nasofrontal peak. Posteriorly, anterior ethmoidal artery. Medially, middle turbinate. Laterally, lamina papyracea. So this is roughly, if you look at the CT scan, it's roughly around 1.2 to 1.5 centimeters. This whole length is around 1.5 centimeters by easily 8 millimeters to 10 millimeters. So that means you opened it completely. It's a all or none phenomenon. Opening the frontal sinus is an all or none phenomenon. You cannot just open this alone. If you open this alone, if it is less than 6, any ostium less than 6 millimeter will stenose. Just take it from me. If you have wrought the surface of all the 360, any ostium less than 6 millimeter, that means one suction tip. One suction tip is 4 millimeters. So if you have that amount, it will stenose. Over long run, you cannot see it because the Bernoulli will act suction of the mucosa and it will stenose. So what you have to do is to open this 1.5 centimeters. This will never stenose by around 1 centimeter. So this is how you finish off with the frontal recess. So this is what I wanted to convey. See how beautifully the skull base is seen. Frontal, anterior ethmoidal artery, posterior fovea, planum, that's the optic nerve. There's a view with a 70-degree telescope. See how nice the cavity looks. Maxilla, you have the sphenoid sinus, the onodi, skull base, and you have the frontal. In a single 0-degree view, you have a 0-degree view, and this is how you want your ideal cavity to be. Well, you've finished this, and then what happens is that you are now going to a different disease called fungal sinusitis. Of course, I don't want to disturb you. Every day I'm planning only half an hour lecture. I don't want to disturb too much. So what we will do is we will stop share now. Wait, escape. Only half an hour, not more than half an hour every day. You are a stop share.
Continue to share. இதுல இது கொடுத்து ஸ்டாப் பண்ணுங்க ஆக மாட்டேங்குது. This is first இந்த சிஸ்டத்துல.
Okay, right. So I just didn't want to pull you long on a Sunday. Every day it's going to be 8:30 to 9. There will be one lecture. Morning will be live surgeries. Today I think we did a lecture on basic concepts in Fess. Of course, this will be elaborated in a big way. And this is all for the postgraduates. I hope you liked the lecture. We can now open it for questions. So ask questions with respect to what we talked today. If you have any questions, you can unmute, and I'm just going to unmute all of you. Allow participants to unmute. I hope you will like this lecture series. Thank you very much. Hello. This will be available on YouTube also.
Good afternoon, Janki.
Sir, namaskar, sir. Shyam Garu.
Only thing is the juniors keep asking me one question.
Yeah.
If they don't have debrider, what to do?
Sir, operating on endoscopic sinus surgery without a debrider is equal to operating on mastoid without a motor nowadays. So there are now debriders. See, there is one debrider which is going to be made, an Indian debrider. I will give you the, nowadays I'm posting, I will try to post it. Mr. Pradeep has made it. And I was just talking to them. Very good debrider. They are coming for a demo now. It's a very cheap one. So if they can't afford the Medtronic, they can get this debrider. I'll put the link. There's a Chinese debrider also. We are trying to work with them and import that from China. I will tell you shortly. But without the debrider, it's going to be very difficult mucosal saving surgery.
Yeah, I
Sir,
can
for
understand.
for long-term course of steroids for nasal polyposis, what is minimal dose, moderate dose, and high doses of steroids? Can you explain and classify the doses?
Actually, sir, this is only for pre-operative. We say mild, moderate.
Pre-operative.
For
Yes.
post-operative, we don't say.
Pre-operative.
Pre-operative, mild means 5 milligram. Okay, 5 milligram is the mild dose, but that doesn't work too much. 30 milligram is moderate and 60 milligram is severe. That's a high dose. So we generally give moderate dose of 30 milligram non-tapered for a week. But post-operatively, we give tapered dose. We start with 30 milligrams and end it with tapered dose. But the problem is you have to do a IgE estimation all before you give steroid and antihistamine. You should remember this, very important. And you should start the patient on either immunotherapy 15 days after the surgery, start the patient on immunotherapy. Because it's very important that if the IgE is high, the patients will have recurrence. So you have to do an allergic test if you see the patient, and you have to start the patient on immunotherapy.
Do you
Nowadays-
test
What mode of
or not?
immunotherapy, sir?
Nowadays, the patients, you can give omalizumab, Xolair. So it is also available. If they are affordable, we can send them to a pulmonologist and we can give Xolair.
Sir, for this nasal polyposis aspirin sensitive test, are you practicing? Or if at all, how do you suggest to the juniors practitioners?
Yeah, basically, see, aspirin hypersensitivity, asthma, all that sometimes can coexist. I find it very rare, boss. At least in Indian scenario, it's very rare. So you give NSAIDs, the patient sometimes very rarely complains of allergy. And if you do that, you have to do desensitization. You can give 100 milligrams. You have to admit the patient in ward and start on small doses and slowly increase the dose. It's basically desensitization. Same like immunotherapy. The concept of immunotherapy, same thing with aspirin also, desensitization. But I find it very rare in my practice, maybe 1 in 5,000, 6,000 patients are what I've seen.
The surgical principles in cystic fibrosis with sinonasal polyposis in child.
What boss? What boss?
Surgical principles in the
Your voice
cystic
is breaking,
fibrosis
boss.
case
Your voice
in
is breaking.
sinonasal polyposis. Yes. Yes, surgical principles in the cystic fibrosis case with sinonasal polyposis, sir.
So nowadays, what we do when we find polyposis in children, maybe less than 10 years or so, we find whether it is just polyp or it is with fungus. That in scan you can see very clearly. And after that, we send the patient for a genetic testing. In that, we have a beautiful CFTR gene, cystic fibrosis transmembrane receptor gene. So that is available in TRICHY also. I am sure it will be available everywhere. Or you can do a sweat chloride test. So, but we do the gene testing, and once we find it, then we have to prognosticate this. The problem is these patients can have it again and again. You can also do an electron microscopy of the this one. You can find the 9th dynein arm missing in a case of cartilaginous. You take an X-ray chest, dextrocardia, 9th dynein arm missing, then you can say it's cartilaginous. But the problem in all these, I've operated on several cartilaginous, several cystic fibrosis, and even recently in Dubai we have done some cases with dextrocardia. The problem is this recurs again and again. So they may be you have to give a guarded prognosis for such cases.
Sir, how often you find?
What?
May I ask one question, sir?
Yeah, sure.
How often you find sinolith formation in maxillary sinus in chronic sinusitis cases, and how you deal with this?
Oh, you mean the sinolith, right?
Yeah,
Sinolith.
I found one of my cases. There was a big sinolith formation in maxilla, and it was very hard osteitis in and around. And how often you find this kind of large sinolith?
Basically, it's rare, boss. It's rare. But sometimes what happens is the fungal ball per se, even yesterday we did a case.
Fungal ball.
Yeah, that fungal ball, the center of the fungal ball can be really, concretions can be there, real concretions.
It was an isolated sinolith formation without any fungal debris or
It's
anything.
rare, boss. It's very rare.
Yeah, I also found this very rare.
Very rare.
Might be foreign body, I think. Migrate foreign. Sir, the next question is nose packing, sir, for every surgery with or with adrenaline, with infiltration or without infiltration.
More
The
than
nose
for
packing is
you,
important.
more than for you, I want to tell my fellows. You see, that my fellows are sitting here. All the 3 fellows, they are not doing properly. Let me tell those fellows. All the fellows are sitting here. Please, my dear friends, whenever you post a case for surgery, half an hour before the surgery, when the patient is in the pre-operative ward, you should pack the nose with 1 in 5,000 adrenaline. Okay, take it. So this is called pre-operative packing. None of my residents do it. I was telling my residents previously they were doing, now nobody is doing. 1 in 5,000, that means 5 cc of distilled water with 1 ampere of adrenaline. Then put it 3 packs in each nose. This is called luminization of the cavity. If it's a gross septal deviation, don't do it. Now, after the patient enters into the theater, you say that case is ready. No. Before that, you should pack. That is called selective nasal packing. Selective nasal packing is done for seeing the middle turbinate. Okay, you have to visualize the middle septal body can be enlarged. So you have to pack the septal body. So that you have to do. You have to cut the vibrissae. Always cut the vibrissae in Fess. And then pack it so that you see the middle turbinate. After that, when I wash up, I do what is called super selective packing. What do I do in super selective packing? I pack between the middle turbinate and the uncinate process. You understand? So you can use whatever you want, Merocil or whatever. But the idea is don't damage the mucosa. Okay, from tomorrow I should not see a lot of bleeding when you pack. It should be with a headlight or something. You should pack nicely. Very gently you should pack. You understand? So there are 3 kinds of packings. So the second and third packing is done with 1 in 1,000 adrenaline. Okay, 3 packs.
Oh.
Yeah, right.
What is the role
Good
of
question.
warm saline wash during surgery?
Yeah, every patient, you should have 2 things in your kitty when you do endoscopic sinus surgery. One, you should have warm saline. This is very important because it produces hemostasis. You can irrigate. Second is you should always have a coblation. You should always have a coblation. Why? Because if you injure the posterior septal branch or if you injure the anterior ethmoidal artery, the best is coblation. Take a coblation, just go and keep it finished. Kalas. You will struggle with the bipolar, you will struggle with everything else. So coblation, we always advocate for all our cases in Fess.
Setting, sir. Setting.
Setting
7-3.
7-3. But you should have it in your this one ready. You cannot say get the coblation after the bleeding comes. You should not say. You should have the coblation ready so that if there is bleeding, immediately go and touch it.
Sir, the role of Vidian neuronectomy in sinonasal polyposis with allergic rhinitis. Are you practicing, or if you do at all, what
I don't do, boss. I don't do.
complications
See,
or
I'll tell you
side
one. Because you
No.
asked this question, I'll tell you one very interesting thing. I think I saw this patient a few days back. No, I saw it in Hyderabad yesterday. I think Sri Asha, if he's watching, he'll tell. See, I did a JNA for one patient. And the patient, we have to cut the Vidian nerve. When you cut the Vidian nerve, if they are very intelligent, they'll complain of dry eyes. Please understand, they'll complain of dry eyes. Especially if the patient has got facial palsy, believe me, it will be a torture. Facial palsy with Vidian neurectomy is a big torture, boss. You will have severe dry eyes. Dry nose, dry eyes, that side. But yesterday, I saw one patient in Hyderabad. She said, for 4 months, I had dry eyes, that guy. But after 4 months, it recovered. She's telling, I can get tears now. I was surprised actually, Vidian nerve recovery, but maybe alternate pathway or something. But what I'm telling all these, I didn't document, but I'm just telling you, yesterday only I saw this. You're asking the question correctly. I generally don't do Vidian neurectomy. What I do is I give immunotherapy. I give immunotherapy post-op. Yeah. Good question. Good question.
For sinonasal polyposis case with sinusitis, the wash, antibiotic wash, what is the antibiotic you use? How do you prepare the solution for wash? I mean, how many times you will wash the sinus cavity?
Boss, I'm telling you, the post-operative care I've still not dealt with. I will come to it. I have a separate lecture on how to follow the
Perioperative also you wash with some solution.
That I'll tell you. No, I have the next lecture is on post-operative care in sinus cavity. I will tell you everything about it. Okay, this itself we are going to elaborate. Many, see, 365 days I'm going to come with you, boss. You're going to see me. So have some questions for the next session. I
Hello.
hope it was useful.
Hello.
Yeah.
So, what can be the problem if we infiltrate with adrenaline and so?
Very good question. Who is this lady, doctor?
I'm Shanal Kothari, sir, from
Very
Indore.
good, very good. From which place?
Indore, sir.
Very nice, very nice. See, very good question actually. Previously, when we started doing Fess, we used to start infiltrating, right? At multiple places, we used to infiltrate. What we used to infiltrate with? We used to infiltrate xylocaine with adrenaline, right? That was for hemostasis. Now you should understand that nasal mucosa is highly vascular. It's highly vascular. So the absorption of adrenaline will be erratic. It can be absorbed just like that. Because, see, it'll just go inside a vessel or it cannot. That's why there are some deaths also reported. But packing of adrenaline will not cause absorption because adrenaline prevents its own absorption. But infiltration, you will get absorption. Now, there was a study where they studied the pulse rate after infiltration versus packing with adrenaline. And they found that the pulse rate increased after infiltration. So what you're asking the anesthetist, you're telling the anesthetist, keep your pulse rate at around 60, 65. And you're infiltrating and causing pulse rate of 90. So you're countering actually what the anesthetist is trying to do. So if you carefully note the pulse oximeter after infiltration, it'll increase. So don't infiltrate adrenaline. Just pack adrenaline. Pack adrenaline, even if the mucosa is raw, that adrenaline will completely prevent its own absorption. It's not directly going into the vessel. If you infiltrate only, it can go into the vessel because the needle will go inside the vessel. So this is the problem.
Yeah, thank you.
Okay. Right.
Sir, pre-operative xylomethazole nostril drops.
Yeah, you
The
don't
role
use.
of the
Don't
pre-operative
use
xylomethazole
only
nostril
for,
drops.
see, oxymetazoline, xylometazoline are competitive inhibitors for adrenaline. So if you use adrenaline intra-op and oxymetazoline pre-op, then you are actually countering the action. So they are competitive, they compete for the same receptor. So don't do that. So your effect of adrenaline will go down. So don't do that.
Sir, in septoplasty also you don't infiltrate?
We infiltrate only saline. Saline is hydrodissection. So we infiltrate saline and we don't infiltrate adrenaline or xylocaine.
Good evening, sir. Sir, nowadays we are seeing how to treat, I mean, how to manage patients having polyps and diabetes.
Diabetes.
Pre-operative, you are before operating, you are giving steroids to treat, I mean, for a better operative field. But in case of diabetes, how to manage that, sir? Kindly.
That's a good question, actually. See, diabetic patients, you should get a diabetologist's opinion, get the sugar under control, and try to avoid. See, what is the use of steroid? Steroid is only for making the field good,
Yes, sir.
not to treat the disease. Please understand. Preoperative or postoperative steroids are just to reduce the inflammation edema, here to make the field good. You don't need always the steroid. We just, how many patients we don't use steroid at all? We straight away operate. So what I mean to say is diabetic, non-diabetic, try to avoid steroid. Deflazacort, some say it's equal power as the almost 50 or 60% the power of prednisolone. Why you want to do that? You don't need to do it.
Okay. Thank you.
So this is the beginning of the lectures, which is going to go all 365 days. And you know what happened to me in the general body. I don't want to talk about it. I want to be a thorough academician. And this is going to be just for the sake of juniors and postgraduates. I hope I can do something good for you. And I'm sure that, you know, you will all support me. Thank you very much. God bless you. Have a happy Sunday.
Thank you, sir. Same to you.
We will see tomorrow morning. I
Yes.
have maxillectomy, and
Sir.
I will tell you the I'll tell you the time, and also I think I have a skull-based osteomyelitis. Let me check what case I can show to you. We'll start with basic cases because I want to show adenoid. By all this, I want this 2026. I want to show all the basic cases first, then advanced cases. So I will cover the complete boss, everything, all topics, snoring, mastoid, ear, otology, cochlear implants. I will catch hold of all the good people around the globe whom I feel are good academicians, and I'll bring them to you right at your doorstep. You will just watch. I'll bring them to you, and these are all available on YouTube, and you will be seeing all these again and again. You can see them and you can learn. This will be a complete library, and also the unedited videos we will upload. So I'm going to upload one peroxidectomy tomorrow, so you can see that. So I think you saw that, Dr. Nageshwar Rao garu, the latest peroxidectomy, pleomorphic adenoma. We will upload that. Okay, thank you very much. God bless you. Bye bye.